So my name's Will Cooley. I'm with the Minnesota Justice Research Center, and this is Overcoming the Barriers of Drug Testing, a Harm Reduction Approach. So the Minnesota Justice Research Center has been studying community supervision this year, looking at what's working and what's not. And one of the things that comes up a lot is substance use, drug testing, and revocations. So I'm going to start off with a story from a recent Robina Institute study on why people on probation lose contact with their agents. So Robert was on probation and engaged in treatment, but he was struggling. The 10 hours of treatment he was required to attend each week was draining on top of his full-time job, and he kept failing urinalysis tests. When he got another substance-related charge, he dropped out of contact with his probation officer because he feared the repercussions. Here's Robert's quote. "The probation officer was already not happy with me because I was failing a lot of UAs. I just thought it was going to be bad and I was going to be violated. I was probably going to end up serving the rest of my time in prison for that and jail for the other thing. I figured I'd just try to wait it out, which was obviously not the right decision." Like many people in Robert's position, he stopped checking in with his probation officer. So community supervision in the United States is supposed to be an alternative to incarceration, but too often it has become a greased slide back into prison. Many violations of supervision result from drug-related issues. There are 3.9 million people under probation or parole in the United States, and most are required to prove they are drug-free. Yet research on drug testing indicates that it's contributing to mass incarceration rather than supporting recovery for people like Robert. So our panel today will explore harm reduction alternatives for people with substance abuse problems, especially people on community supervision. So we have two panelists with us today, Latasha Jennings and Dr. Ronda Chakolis. We're going to start off with a presentation from Latasha Jennings. Latasha earned her master's degree from the University of Virginia. She's the project manager at LEAD, Let Everyone Advance with Dignity, here in Minnesota. The LEAD program focuses on diverting individuals away from low-level, nonviolent law violations related to unmet behavioral health needs. Her role involves orchestrating partnerships amongst law enforcement, health agencies, community members, and civil rights advocates to redirect individuals into long-term community care instead of arrest. So Latasha Jennings will give her presentation, and then we'll have Dr. Ronda Chakolis give her presentation. I'll introduce her before she speaks. But if you have questions, feel free to throw them into chat or the Q&A. I see there's a lot of probation officers, parole officers in the room, which is great. We tried to invite as many as possible to try to get into the nitty-gritty, some of the questions that are come up. So please feel free to put any questions in the chat. So I'm going to turn it over to you, Ms. Jennings.
Thank you, and good evening, everyone. Thank you for taking time out of your evenings to join us here today. As Will mentioned and introduced me, I'm Latasha Jennings. I'm the project manager for a program called Lead Minneapolis, which is a program of Pillsbury United Communities, a nonprofit organization in Minneapolis, Minnesota. Our program focuses on providing an alternative public safety pathway for individuals who are engaged in low-level nonviolent law violations, as Will said, due to behavioral health needs, homelessness, or extreme poverty. We take in referrals directly from community members. Our case management approaches are rooted in harm reduction principles. And our services are lifelong. So if an individual comes into our program needing support, there's no end date for that support. We're very person-centered and participant-driven when it comes to setting case plans and goals. And abstinence from substance use is not a requirement for our program. We'll take anyone anywhere along the spectrum of where they are in terms of being ready, willing, and able to enter or think about entering treatment services. And so I approach this conversation from a service provider perspective. In addition to LEAD, Minneapolis in my work now, I've also spent time working in a local community corrections department as a racial health equity planner as well. So I have a little bit of an idea or a little bit of background in a couple of different areas around this topic. When it comes to drug testing, for me as a service provider, and a lot of the work that my case management team does in terms of advocacy for our clients, with drug testing, that doesn't necessarily, from my perspective as a service provider, tell me whether or not, if it's positive, whether or not that drug use is something that is an impact directly to that individual's life or to the people and community around them. And so for me, it's more important to understand, is this use related to any sort of problematic behaviors that might be popping up in community or popping up in their relationships? And for me, if not, that's an important context that I like to sort of keep in mind as well. So, for our folks, our focus is on reducing harm, teaching them and helping them understand, what are safe use practices. Do you have a friend or someone in your network where you can, if you are using with someone? We take in a more holistic sort of picture in terms of, like I mentioned earlier, how does a substance use show up in this person's life? Is it impacting their relationships and things like that?
Thanks, Latasha. So one quick follow-up there. How have you been interacting? Because I assume some of the folks are on probation or supervised release. How have you been interacting with agents?
Yeah, thank you for that question. A large part of our work is collaborative. So every other week for the lead model and program, we meet with a group of individuals, including a probation officer and liaison, with our local city attorney's office, with social workers from Health and Human Services as well as individuals from a crime prevention specialist, for example, within the Minneapolis Police Department. So we provide that additional context of, that contextual information around and advocacy around why we may not think that a positive drug test is indicative of someone necessarily needing a punitive response from the criminal legal system, but rather, are there health or social service need gaps? And are there ways that we are supporting that person, that client, and community? Are there still progress that they're making on their case plan? Have they been recently housed if they're unsheltered? Are they engaged in treatment? But, we know that recovery is not a linear path or a journey. And it comes with progress and setbacks. And that's just sort of the reality of what a substance use disorder is. And so we operate and advocate on behalf of community-based supports and services as an alternative for someone potentially getting revoked on probation or supervised release or something like that. So we bring that extra picture of what else is going on in this person's life. And what do we think is going to be a more appropriate alternative that over the long term is going to support their success in community and help them avoid repeating a cycle of systems involvement and criminal legal system involvement.
Great, thanks. And we'll have more questions, of course, that'll come in for our panelists. And I see that chat is disabled, but you can use the Q&A if questions come up throughout the session. But right now, I'm going to turn it over to Dr. Ronda Chakolis.
Good evening, Dr. Ronda Marie Chakolis. I'm a pharmacist. I am your current Minnesota Board of Pharmacy president. I do have to make my normal disclaimer that my views that I'm expressing here are solely my own. They don't necessarily represent the board or any of the my other affiliates. And so I think one of the things that we can do is really start with a story here. I come into contact with people who are looking for ways around drug testing, unfortunately, because I'm a clinical pharmacist or I'm a pharmacist practicing still in the community. About 3 years ago, I had a young man who knew they had a UA potentially coming up. and was on that list, and said his probation officer wasn't good with him. And so much like a lot of people do, right? They go to the school of WebMD or they go online to try to look and find ways to clean their system. Unfortunately, this young man, after I talked to him, he went and got a bottle of niacin. He pretty much took the whole bottle and went into liver failure. And that's how serious he wanted to avoid those consequences. It is a very punitive system. It can be very burdensome. I've heard people in community sometimes just not really having the resources that they need. That particular gentleman said to him, it was like the area that he was put back into that would cause him to use. His environment didn't change. He was told time and time again that if he does things, things would get better for him. But he was like, once I stopped using and I didn't have that support, it was like the rose-colored glasses came off, and I became all too aware that things were unequal, that things weren't in place for me. And that story has stuck with me for a long time. When I talk to young pharmacists and people in the community, I share that story because, you know, this young man now too, because of the substance use issue, wasn't a candidate either for a liver transplant. And so we definitely have to do better with handling these situations. So thank you for letting me share that story. I'm very open for questions as well.
Great. Thank you, Doctor. Our third panelist is a pinch hitter tonight. We wanted someone with some lived experience. I know that term gets thrown around a lot lately, but it is important. And Ed Krumpotich from the Minnesota Harm Reduction Collaborative is our third panelist. Ed, do you want to introduce yourself? Because you've kind of gone from someone who is living it to someone who's now very active in advising on how to handle it.
Yeah, good evening, everybody, and thank you for having me. My name is Edward Krumpotich. I am the current policy lead for the Minnesota Harm Reduction Collaborative. And like Will said, I'm also a person of lived experience. And what that means to me is that I have been using substances since the age of 14, including methamphetamine and others. I have been in substance use disorder and also over 40 treatments across the state of Minnesota. The state of Minnesota has paid over $15 million for my care. And I chose radical therapies in order to find a pathway to recovery. What I think is also notable is that many times we get lost in what substance use disorder patients or clients or individuals look like. I'm also a social studies and history, social studies teacher of the year in the state of Maryland. I have a master's degree, and I also walked the streets homeless in the state of Minnesota for about 6 years. So obviously we know this does not discriminate. I was the lead writer of the changes to Minnesota's paraphernalia laws last year, including the expansion of syringe service providers, protections, and legalization of drug paraphernalia and drug residue. So obviously I used some of my education background to parlay into personal and what I would consider to be mental health and substance use and criminal justice advocacy. It is clear that in the state of Minnesota since 1970, we've seen a 282% increase in incarceration efforts up to 2015. And during a similar time period, we saw a 342% increase in overdose. Many times we look at things like prohibition, for example, where the United States decided at one time to make alcohol illegal, remove the scourge, as they called it, in historical literature from society. They gave it about 13 years and realized it was a giant mistake. They said this increased gang violence. It created mobsters, speakeasies, and illicit substances and an illicit market. So I want to repeat that. It created the illicit market. And so they decided in a half of a generation that they wanted to remove those penalizations against alcohol. They made a deal. They understood that alcohol was a substance that was needed in our country. They also knew that alcohol was most likely going to be toxic to some. Come 1970 and 1971, the Nixon administration decided very similarly to put restrictions on most substances and scheduled substances, and in the United States called the drug war. Things like psychedelics, cannabis, ketamine, and other evidence-based treatments like methadone began to be restricted. And in 3 generations, we have seen the exact same results, which include increased gang violence, a creation of the illicit market, and in this case, death. And so we know that this system of incarcerative penalties does not work. Minnesota has taken the lead in the last year, including with the legalization of drug paraphernalia and others, not only to work with the incarcerative system, but to amend and to treat substance use as a public health, and I repeat that, a public health issue. It's a pleasure to be here as a person of lived experience first, and I'm looking forward to the event.
Great. Thank you, Ed. So I think the first question, and I encourage audience members to put more questions in the Q&A, but the first question is a rather long one, but it's about, and I think we'll go to Latasha first, about people who feel like they have this substance abuse problem and they just keep getting caught up in the criminal justice system and can't get out, right? And they're never able to access those supportive services. Is that what you're seeing in your experience, Latasha? And how can we change that paradigm? Ed talked about it, Edward, that a lot of money spent on punishment, right? A lot of money spent on coercion. How do we help people get those services?
Thank you, Will. As I was listening to both Dr. Chakolis and Edward, one of the things that I was thinking about too is that I think one of the key things that I hear over and over from clients in my program is that there's a lot of pain at the heart of substance use, and that there's a portion that is self-medication that is happening too. And so when I think about pain, when I think about trauma, I think about the lack of community-based mental health supports and accessible healthcare for individuals to really get to the root cause of what is driving that substance use that is then driving that connection and interaction with the criminal legal system. So for me, I think about what are ways that we can bolster our public health responses to this prominent problem across our community. And so that's where I see the need for additional resources and gap fillers to really meet the need, the volume of the need of very real pain and trauma that's in communities.
Ed, can you think of a time in your life when you needed the carrot and you got the stick, a very expensive stick instead?
Can you repeat the question? So what I heard you say was got the very expensive stick. What do you mean by that?
You needed the carrot. You needed supportive services, right? You needed help. Instead, you got punishment. You got time behind bars.
So we know that through lots of scientific efforts that we'll call it forced treatment does not work, because the choice to be treated ends up with someone loses, like myself. I lost my own self-advocacy. I have been in jail 3 times since I have a sad substance use disorder. I take that very seriously, because people who, as somebody who has a master's degree and used methamphetamine since the age of 19, for example, the color of my skin, being from the East Coast, has led to a very privileged life. And what I mean by that is when I'm pulled over, high and intoxicated in methamphetamine, I had a strong diversion from jail just by the way that I looked and presented myself. And so that is one thing that we fight heavily. However, in those moments where I was forced into what I would consider to be treatment or to jail, I relapsed on each occasion. The most important thing to note is that science has been showing this for decades. If someone goes into incarceration, and especially here in the state of Minnesota, most counties, and this does not count for all, but most counties do not have medicated assisted treatment, for example. And so when we come out and we lose our tolerance, right? So I used methamphetamine, my chances of overdose were lower unless it was laced for fentanyl. One interesting story was the last time I went into detox, I tested positive as a methamphetamine user for MDMA and fentanyl. And so I had not used either of those, which is why, and I carry my fentanyl test strips everywhere I go to support. However, we also know that incarceration has a long way to go. For example, our current bill that we've been writing in the legislature, we know that somebody who incurs a felony penalty for a 5th degree possession, and this is under 0.25 grams of a narcotic, will lose their housing, their employment, may lose their housing, employment, custody, And these are our Black, Brown, and Indigenous populations. And so then we say to these individuals, get a job, find a way out of this. The system has broken their back. The system has hampered their ability. We wouldn't tell somebody, for example, with diabetes, whose blood sugar goes up naturally in what we would call a relapsed phase, to stop eating sugar or to, to do something or to incarcerate them. However, when somebody slips one time, we tell them that they're not good enough. And so this system is clearly broken.
So I think that's a good segue to you, Dr. Chakolis, because we heard about Medicaid, medical assisted therapy. Yes, yeah. MAT, right? MAT programs, and you're an educator of pharmacists, and so you deal with a lot of future health professionals. But I still hear a lot of skepticism from the public on these programs, right? That it seems like a lot of the public would still rather turn to incarceration over just replacing one substance with another. I think that's what I often hear, right? So you've got a lot of experience with this. What do you say to folks that you're educating and the public on the importance of MAT and other treatments?
That's a wonderful and loaded question. But if you know me, one thing that Eddie and I have in common is that we're both, I'm a history major. And I think in undergrad, that's what I studied. And so decriminalization of drug and drug paraphernalia is not new. We could look to the country of Portugal, who started this process in like 2001, right? And what we've learned is that they were able to reduce HIV rates. They were one of the highest HIV capitals in the world. But what they did was they put their money where their mouth is, and they put substance use disorder persons with treatment such as MAT. They combined it with workforce. They've done a lot of things. However, what has happened is they haven't had the money to fuel it long term. And so now we're seeing a regression of that. So I want to throw that out there as a way and lessons learned, because in my field, people are always saying we need best practices, we need a model. By the time we study a model, the methods are outdated, the population isn't the same. And so we have to be flexible and willing to approach and pivot. And so here is what I know as a pharmacist: the substances that are out there now alter the brain chemistry in a way that they have never done it before. And so even when we look at medication-assisted treatment, such as something as Suboxone or buprenorphine, what we find is that the current FDA prescribed doses are not even enough to reduce the cravings. We're seeing that it's just not enough, but we're also seeing supply chain issues. So you imagine you have somebody who's out on parole, or who has been court ordered, or who has MAT, and they go to the pharmacy to get a life-saving and life-changing medication, and they don't have access to it because of supply chain issues, or they don't have access to it because of insurance. You think about it, I've had one person tell me it's much easier for them to use heroin than it is to spend $30 or $40 on Suboxone in the pharmacy. And that's heartbreaking when people are having to make those choices. But if we look at the science and the pharmacology, if we know better, we do better, right? So we think about people who are diabetics, and I love Eddie's analogy. I would not tell a diabetic, I'm not going to give you insulin to lower your blood sugar. And because we know we need to lower the blood sugar. That's the same philosophy that I have with MAT. Again, we think about substances that are very legal, that can also change your mood. You think about cigarettes, they're legal. Alcohol is legal. Caffeine is legal. And we need to kind of get behind the science and alter our approach and really understand that this is a different phenomenon that we're dealing with.
Thank you. Latasha?
Yeah, I'd like to chime in here too with a little bit of data. We know that research has shown that in the 2 weeks following a person's release from incarceration, they're 12 times more likely to die in that 2-week period. And that death is largely driven by overdose. That point in time is a very critical point. It's 1, 2, where there are multiple sort of public health models that have been added to whether that's, medications for opioid use disorder being provided in some jails and prisons now, but then also thinking about the support through that transition from release to connection back to a community-based clinic for that follow-up care to continue. And so I know that there are some folks on the call. I see some Department of Corrections and corrections related individuals and participants. So I also wanted to sort of call out, there's a lot that I won't go into a lot of detail about, but if you're thinking about what are some practical ways or some options that might be available, I'd be happy as a follow-up to this panel for folks to reach out to me, and would be happy to talk about that.
Yeah, I see in the Q&A that people have already asked for the three of you to put your contact information in there. So if you could, I don't know where it would go exactly if the chat is disabled, but maybe right into the Q&A. But I'll make sure that everyone gets that contact information for the panelists. So, and yeah, I encourage people to use the Q&A. There are a lot of probation and parole and corrections folks in the room, and we'd love to hear good, hard questions from you, right? With them, we're not going to shy away from any difficult questions. And I'm going to have one right here. This is also from the Rabina study. And I think this is one of those cases that the public really struggles to understand. So Rabina Institute interviewed a woman on probation who admitted she did not plan to stop using drugs and would commit crimes to buy drugs. Quote, "I don't want to be sober. I didn't want to not commit crimes because I needed to commit crimes to get the money." So is there a harm reduction response to cases like this? And how do you sell that to the public? And maybe we'll start with Latasha.
Sure. I think this is a sort of scenario that applies to a lot of individuals who are enrolled and actively engaging in intensive case management services through my program. That's a short vignette, but what we would do, or what my case manager would do, is really dig into that a little bit more. I often see that there is housing instability that plays a role in that. If we probably, one of the first questions I would ask is, okay, are there other ways or opportunities for you to make money? We're not going to tell you to stop. Our goal isn't to tell you to stop using drugs or anything like that. And we're not doing that we're not passing judgment on that, but to just really dig into and underscore what are those underlying, what in the public health field we call social determinants of health. There's usually some basic need in there that is lacking. Or we use motivational interviewing techniques too. So we try to tap into what is important to you, what motivates you, where do you see yourself tomorrow or next week, or if there is a better future for you, what does that look like? And then we support them in figuring out what are the steps to get you there. So I'd say it's usually that's a very surface level, one of the first conversations we might have with an individual. But once we start peeling back those layers of the onion, as the analogy goes, there's usually something else that's at the root of that. And we'll tap into that and figure out a way. Is there an intervention? Is there a resource? Is there a support that we can provide that gets at the root cause of either if it's employment and a need for access to funds, whether it's housing, whether it's I would love to get a job, but I don't have an ID. We will pay for the fees to support someone getting an ID or going back to get their social security card because they may not have that either. There's usually things behind that, and people have goals and hopes for themselves. And so we tap into that and try to understand that a little bit more to support them.
Dr. Chakolis, do you have anything on this? Because I think I hear this from a lot of people that a lot of people have changed their minds on substance abuse, but not when people commit crimes to support their substance abuse, right? So how do you respond to this?
I think we have to kind of go back to and just understand my perspective is really from the clinical perspective in the clinical world, right? When we look at this case, right? When I'm trained in school, we have what we call guidelines. And what I've seen happen is people start to check the boxes. When you hear cases like this, we know that we don't have a one size fits all approach, right? And again, what is the incentive that people have to not do this, right? What is the incentive that people have? We come from a very clinical or punitive mindset. And there's really no incentive to stay clean, or there's really no incentive to want to get treatment. And like my colleague Latasha said, what is the root cause? Like, we have this trauma that's there. We have some things that, again, and I hear this all the time. Well, people tell me if I go do this, and I go through all of these pathways, and then all of a sudden, every time I'm getting the door slammed on me, it's not helping. So I like to use personal stories to kind of help people make that connection. So one story I had was somebody who was part of their probation stuff. They went through treatment, they went through education. Somebody thought it would be a great idea for them to become a pharmacy tech. They did the background, they did everything else. And of course, because of what was in their background, they set them up for failure. And because of that failure, this person relapsed and really just lost trust in the system. So a lot of times, like, sometimes we assume that this is a moral or ethical issue, but sometimes these behaviors are facilitated by a breakdown in the system and the lack of trust. And so we have to remember to see people as humans. I also remember and remind people that we love our things, but they are things. Things can be replaced. You have insurance. Most of us should have it, but we cannot replace humans. And even people who are in recovery or struggling with substance use disorder, they are a human. They are worthy of compassion, and they are worthy of investment in resources and time.
Ed, I'm sure you've got this question a lot from legislators, right? I mean, this sounds like a person that a lot of legislators would say, no, I think this person needs to be locked up. How do you respond to that?
This is right up my alley, and it's not a short-term solution. And the symptom of substance use disorder is bad behavior. So, this is one of the hardest parts about the disease of addiction. I call it substance use disorder. Some call it addiction. We try to use person first and empathetic language. However, I'm going to use diabetes again. I'm not trouncing on diabetics, but I want to make the point. When you go to a provider and you have diabetes, the first thing you hear is the word moderacy. You hear moderacy. You don't hear somebody in the provider go, what I need you to do is never eat sugar again. You don't hear that, right? That's not something that gets said. So somebody goes home, they go out, they eat sugar, they go, oh gosh, here we go. I messed up, right? However, the sugar is still available, right? So they find a way into their moderate lifestyle, and their homeostatic, the way that their homeostasis works is that it's easy. This long-term solution is a safe supply of substances. And let me give you my example to make it. I went to 40 treatment centers, abstinence-based care. And I, at this point, was homeless and long gone. And I decided to think outside the box with providers. And they said, Eddie, we're going to treat your ADHD, and we're also going to give you a safe supply of stimulants. That's right, stimulants. I have a probation officer, and by the way, who I love, my probation officer, and I get along great. So when I've been to jail, I've been treated really well. And so I want to throw that out there too. It doesn't work, but I've been treated really well. But what I do is I'm using a stimulant as my safe supply. So the example that Will shared with somebody was if somebody doesn't have their supply, they're going to go and they're going to steal to get it. I have not been to treatment since I started that, not one time. And so what my brain has now done is it made its own bargain. It said, now that I have a safe supply of a medication that mimics, same thing as methadone, same thing as Suboxone. Now that I have a safe supply that does this, we are okay. So since that time, I have an apartment, and I'm now obviously prominent in the legislature. And so I write all these bills, and a safe supply of these substances is, as we increase access, will begin to lower crime. And I do want to note that Minneapolis has done a good job this year with new laws in place, including paraphernalia laws and others, of the reduction in violent crime and others. So we're seeing a trend downward.
So you've talked a lot about this model of addiction and the disease model. I think that's the way a lot of people talk about it. So I'm going to come back with a question, and this was just in the New York Times, criticizing this model, saying that the disease model of addiction, it doesn't work because addicts are not merely sick people trying to get well, like cancer sufferers who are in need of chemotherapy. Instead, they will often do just about anything to get high, including engaging in self-destructive and criminal behaviors. Addiction is a lifestyle that decriminalization facilitates. That's not my words. That's coming from the New York Times, right? A recent article. So they say this doesn't work in the same way that diabetes or cancer does. So Ed, maybe we'll start with you since you've used that model a lot. How do you respond to those critics?
So I don't look, we can call it disease, we can call it anything else, but here we go with diabetes again. So people are like, well, is diabetes a disease of the pancreas? Is it? Is it really a disease of the pancreas? Where did it start? It started with an unhealthy attachment due to genes that were expressed epigenetically in the brain, in the nucleus accumbens and the ventral tegmental area, which are our primordial drive, seek, dopaminergic expression. So in essence, I'm eating too many donuts. And all of a sudden, the disease of diabetes gets into the pancreas. But let's not call a spade here. Diabetes is substance use disorder. It is an unhealthy attachment to a lifestyle choice. And so when we look at the ways to get back, we say, okay, moderation. So this individual is now saying, so we're going to use incarcerative and penal methods to do this. I'd like to ask a question. Where is the representation of decriminalization? Where is the representation and the studies? Because to my knowledge, I have read 0 studies that say that increased incarceration has worked. And in 50 years, I have seen 0 evidence that we have pivoted to these methods. So people will go, oh, Oregon is one of these examples. This is the first one in 50 years. In 50 years. And so when individuals start getting tired of this, I want each person, when they sip their alcohol and they sip it, to think about the 15 years that existed when people could not do that and your grandmother was making it in her bathtub. That is where we're at.
Mm-hmm. Dr. Chakolis, I hear this a lot in my classes, right? I talk about the diabetes compared to substance abuse, but I'll usually have a student come back and say, well, you know, my father-in-law has diabetes, but my cousin is addicted, and it just doesn't seem the same to them, right? It seems different, and maybe that's just a mindset, but how do you respond?
Well, that article is so heavy, right? How many people actually say, like, that's a lot of assumptions to say people want to be well. I can say, like, for in the African American community, people have accepted diabetes as a norm almost. So, like, they talk about sugar, it's almost normalized to get your leg amputated, your toes amputated. But even I think about, like, in terms of people with high blood pressure, how many people have high blood pressure and go and eat hot Cheetos, or all of these things where we're assuming, that's making a lot of assumptions that people fundamentally want to be well. Or I'll take it a step further when we talk about hypertension and diabetes, that they have access to high quality foods and resources in the first place. And so when we look at substance use disorder, do people have access to the treatment of providers that are reflective of them? Do they have access to treatment that make use of the most cutting edge technology, which we know is, medication assisted treatment paired with other things? It is very frustrating for me, but I tell people, I won't call out the chain of a coffee shop, but I encourage people to go to a coffee shop in the morning and see what happens when people's order has one extra pump of cinnamon and it had non-dairy milk instead of dairy milk. That gives you an idea of what it's like to have substance use disorder. However, that behavior is culturally acceptable, right? Because we have our caffeine. You actually, those coffee shops are brilliant because they take 2 powerful drugs, and I tell you they're drugs, caffeine and sugar together, and they pair them together and you get that dopamine response, and you want to go back, and you find yourself, for some people, are actually spending more money on coffee than they would a substance use disorder. But we're not talking about that. Some people enjoy that $8 cup of coffee when they know it's not good for their other medical conditions. So we have to be mindful of how we frame the message. We have to be mindful to see people as humans and try to kind of refrain from that judgment. Even when I see patients in the community, I don't tell a diabetic person, or I don't tell a person with high blood pressure, don't do 500 things. I try to build capacity and give them 3 things that they can do. And what happens when we talk about substance use disorder, we just stop at the surface level. We pass that judgment, we pass those moral views, and we just don't put resources in people's hands. And so we're assuming that they don't want to be well, but most people want to be well.
Yeah. I gotta say, you're making me very thirsty for my morning coffee here, Ronda. I'm thinking about the Get Down Coffee Shop in Camden in North Minneapolis, and I think I'm going to hit that tomorrow. So, Latasha, I'm going to finish with you on this question because this kind of seems like a personal attack on you and your profession too, right? That you guys are enabling this behavior. So, how do you respond?
Yeah, I think that both Edward and Dr. Chakolis gave a beautiful description of the brain chemistry aspect of it and the biological manifestations of it. I go back to the cancer example. I think that it is easier for some individuals to conceptualize a disease when there is a physical manifestation of it. With cancer, you can see that tumor on an image. And sometimes you might be able to see it physically on the outside as well, depending on the cancer. But there's that physical manifestation. You can point to something and you can see it as a disease or as a condition or as a problem that needs treatment. I go back to thinking about the mental and emotional component of it. You can't see mental health necessarily. You can't see the things that people may be processing in their brains. And you can't see, it's I think well known that there's a disproportionate number of Black, African American, and Native individuals who are impacted by co-occurring substance use, mental health conditions, and an overlap, a disproportionate representation within the criminal legal system combined with those behavioral health needs. And it's harder to see, too, the centuries of intergenerational trauma and pain that has been passed down through the generations due to historical and systemic racism that still manifests itself in many systems, whether that's healthcare, the criminal legal system. You can't necessarily see the impact of attempted genocide or the boarding schools for our Indigenous relatives in Minnesota. But those things still have an impact that you can't see. And so I think about the mental health conditions, the manifestations of centuries of oppression being the root cause of, and what substance use has been the symptom of. It's the treatment of those ills that you can't see physically in the same way that you can see or understand a physical health condition like cancer or like diabetes. And so I think about it as that way. It's that there's still, I don't know if even disease is the right word that I'd want to use for it, but there are those factors that's contributing to what people are treating with the use of substances.
Mm-hmm. So Ed brought up Oregon, and we should talk about this. It does appear to be a model that's pulling away from the war on drugs, harm reduction model, a decriminalization model, and understanding that what we were doing wasn't working. However, not a week goes by where I don't read something about people talking about repeal, people talking about mistakes. There's been a bit of a backlash, and some of it seems to be coming from an honest, good faith place of, I feel like things aren't working the way I thought they were going to. I just read last week, and it was a probation officer who you could really tell felt like he just doesn't have any influence anymore in trying to make people's lives better. And he feels like he's just getting ignored, and he doesn't have the ability to even direct people towards services that would help, right? And I think this was coming from a good faith place. So I'm going to go to all three of you. You've probably looked at Oregon, and we seem to be moving towards a harm reduction model here in Minnesota, which is good in so many ways, but we want to do it right. And we don't want the backlash, and we don't want it to be repealed almost as soon as it's passed, right? So is there one thing that one or two things maybe you see in Oregon that we don't want that model here in Minnesota? We want to do it differently. I thought, one of the things, Latasha, you talked about the infrastructure, right? And actually having services for people. I've heard people say that in Oregon, that they kind of put the cart before the horse here, right? They decriminalize and then they're like, oh, now we should have our services. So maybe we'll start with you, Ronda. Anything that you see in Oregon where let's not repeat that here in Minnesota?
Yeah, I think that's a fabulous question. And I think I kind of led with that with Portugal, right? We always talk about best practices, right? Um, we need to have those services in place. They need to be funded, but they also need to be able to pivot, right? A lot of times we're not using um, people with lived experience or people in the community to develop these resources or programs. We have this very prescriptive way. So, for example, one thing that I feel very strongly about is like the use of Narcan, for example. Narcan is great, it can save a life, but it also can take a life. And when I want people to think about that, Narcan can save a life, but it can also take a life. And it can take a life when it's not paired with services. So, what I know and what I've seen in Oregon and other places is that there's an emphasis on the use of Narcan or something, that's an immediate fix. It makes people feel good. It's like Grey's Anatomy and ER, and you're like, I really saved a life. But what you don't realize is that withdrawal is so strong that when I don't pair it with medication assisted treatment, people are more likely to overdose after Narcan. And so we want to have those things available. We want to have culturally competent. And when I say these words, I mean not the buzzwords. We want to have culturally competent providers. We actually want to be able to model other states. Other states, pharmacists can work in collaboration with prescribers and do medication assisted treatment. We want to meet people where they're at, not where we want them to be. And I think that's what's happened in Oregon. I think with people like Latasha and Eddie and Pearl Evans and yourself, I am very hopeful that things will change. I will say, like, the passion, the voices are being heard, and they're getting clinicians and even people in school to think differently. So I think that's where we have an opportunity to change things.
Ed, you're at the Capitol, you're writing legislation. You look to Oregon and you say, I would have, I won't do it that way, right? Is there something that sticks out to you?
Yeah, Oregon has, it's easy to do things in hindsight. However, Oregon's law met Oregon. And so one of the things you mentioned, Will, was like, well, I didn't, and the probation officer was really nice. Like, well, I didn't expect this. That was one of the problems, was expectations. So you have 50 years worth of drug war. You have 1 year of a policy and everyone's like, oh, thank goodness. Overdoses are going to go way down now. We're not going to have, no, that's not how it works. So that's, our goals were misaligned. Our goals were not correct. So thing that we look at is like Oregon had since 2000, to Latasha's point, a increase in unhoused populations exponentially. So upwards of 50%. That's a large number. And so what Measure 110 did is it really put a lot, and that's over $300 million into infrastructure. So I can't go out and build a treatment center in an afternoon, right? But what I can say is that over a period of 5 years, $300 million is going to be really beneficial to the state. And I think Oregon knows that. They're trying to fix a couple of things along with the bill. Here in Minnesota, I'm going to give us a knock on wood because we have done things what I would consider to be spot on. And so we did what we would call decrim light with paraphernalia and legalization. I want to tell you guys what's happened in less than 1 year since. We have a lower amount of syringe litter. We have a higher amount of syringe litter return. We have an exponential increase in participation at syringe service providers and public health. And this includes acute and new cases. We're seeing, and we can't make this causal, right? We're seeing a reduction in crime in the city of Minneapolis. We're seeing a reduction in violent crime in the city of Minneapolis. And so these are not, we can't just put these in a bubble, right? but we took things slow, and we obviously made incremental progress towards what, some would say is decriminalization. We were the first state in the United States, the first to legalize all drug paraphernalia and drug residue, number one. And so we got some good notoriety, and then we were all catching our breath to see what our stats would, to see what our, if you guys play sports, our stats would look like. And wouldn't you know, we've hit it out of the park so far. So we're doing real well.
Tasha, any lessons from Oregon?
Yeah, and actually, there's some, I think Oregon as a state did decriminalization, but I think we're seeing that even in like small pockets here locally. I've been, I think, happy to see and enthusiastic to see, even law enforcement saying, we don't want to arrest people who are struggling with substance use. We don't want to arrest people who are struggling with mental health needs. And we're seeing that in small ways, I think, depending on where your proximity to that. We're seeing an increase in homeless encampments in the South Minneapolis area. We've seen that has been a cycle that's repeated year after year in the past 5 years or so. We're seeing some small impacts here of the criminal legal system saying we don't want to have a punitive response here. And that's where my work sort of comes in, and we're serving and working with those folks to help keep them in community. But what I see is, like I said earlier, is there's the lack of housing. Housing is one. Housing first options that are conducive to the complex physical health, mental health, and chemical health needs of individuals. And so I think when we think about decriminalization here, I think about how do we bolster our housing and public health supports in community to address the needs of individuals, and that sort of in a community-based care sort of approach, rooted in public health principles. And so I see it bubbling up a little bit already. And some of my closest and strongest partners in this work are folks who work in probation, are individuals who work in law enforcement, who want to see this sort of alternative response, who are trying to do this work a little bit already in reducing their punitive responses to health and social needs and community. And I'm seeing every day, everyone saying, or a client is asking, can you help me get housing? Can you help me get housing? We can get you on that coordinated entry waiting list. We can look at alternative options. We can help with that, we can help provide an array of options and see what we can get you into. And for some folks, that process moves faster. Whether it's a month where someone gets maybe a 30-day slot in a shelter, or there are some folks that we have on our caseloads for several months who are still waiting. The housing piece is a really big portion of it. And then coupling that with, again, I see a high number of Indigenous individuals, and we see in our client caseloads as well. So how do we reframe or rethink how we think about treatment? It's right now I see a lot of very like Western medicine clinical spaces, and in conversations with the Indigenous community in Minneapolis, I'm realizing that is not what is going to work. People want a sense of community. And right now it's more of a, you get your slot, your friend may get another slot, or if you have a partner, you may not get the same slot or location, whether that's housing or a treatment option. And so you're making that trade-off of potentially losing your community. So how do we shift the services that we're providing to be responsive to the culture and the community that folks have formed in right now? And how do we retain that as they move into housing, for example? The homeless assistance response team, the HURT team in St. Paul, for example, they've shared how they have tried to, for groups of individuals, I think up to 13 individuals who wanted to stay together, they worked with a private landlord to house that group, that family together versus having them separate. So how do we create health, social service, and housing systems that are more flexible to meet the unique needs, recognizing that when people have autonomy and have choice and have options, and they deserve autonomy and choice and options, we're likely to see a higher likelihood of success, whatever that means for that individual. And sort of their stability in that next step that they take in their journey. And so I come back to, how do we bolster, again, those health, those social services, those housing services in a way that's responsive to the particular populations and particular cultural backgrounds to get ahead of what could come as increased decriminalization or legislation is passed here in Minnesota to make that more statewide.
Mm-hmm. So I think in that vein of housing, one of the issues that's come up, Latasha and others, is the safe injection sites. And for those of you in the Zoom room that don't know, right, some cities, Vancouver, places in Australia, as well as some American cities, are starting to experiment with safe injection sites, places people can go use drugs safely, either reverse overdoses or have some sort of medical grade drug where the overdoses don't happen in the first place because people know what they're injecting. And I think a lot of people are signing on to this idea. However, I notice with my students, and we'll start with you, Rhonda, that a lot of students say, yes, this is a good idea. And even the ones that are pro rehab say, well, you can't be in rehab if you're not alive. And so let's save lives first and then worry about people recovering, right? But I also notice that almost no one says, yes, I want this in my neighborhood, right? And a lot of them are rather open about, let's put it in the bad neighborhood and not in Edina, not in Farmington, not in Lakeville, right? So how do you see the future of supervised injection sites, Rhonda, and how do we make sure that they don't degrade the neighborhood around them?
So, I mean, that's, when you think about it, when we say even the term degrade, right? It's already saying that this group of individuals is not worth life and they're undesirable, right? And so for me, as a person who sees everybody as human, that's heartbreaking. These safe injection sites, one, we need community buy-in, but if it needs to be in Edina, it should be in Edina. If it needs to be in South Minneapolis, if it needs to be near downtown, it should be. But again, we have to get community buy-in and really start getting to the point where we think about the stigma. And so when I think about substance use disorder, I certainly think about HIV. And I think about initially when HIV came on the scene, nobody wanted any HIV patients. Nobody wanted to touch anybody with this. Nobody did anything with them and didn't see them as human. And then Magic Johnson came on the scene, and all of a sudden people could identify that this is somebody living and breathing and affluent and didn't have these things. And I think, again, we have a lot of stigma about who is injecting, right? I can tell you there are professionals that I know that are injecting using drugs, but they're afforded certain resources and they're afforded certain levels of protection. And so we have to really start thinking about, yes, we need community buy-in, but even how we frame the message. A lot of times when I hear people talk about these sites, they frown their face up. They say words that are very stigmatizing. And so we need to be mindful of that language.
All right, I see a question in the Q&A here, and I'm going to send it to Latasha, I think, right? I lost it here now. Let me find it again. So I think it's about people being blocked, right, from getting these services because there's a probation agent in the way, there's law enforcement in the way. How do we break down these barriers to make sure, I mean, what you're providing, Latasha, sounds good to me, but I'm sure you are coming up against times when people are blocked from getting your services.
So we actually, the lead model that we're implementing, our referrals come in from community members. Some folks on the call might be familiar with LEAD as law enforcement assisted diversion, and law enforcement were the gatekeepers and referrers into the program and sort of had that decision-making power. So we've sort of shifted the paradigm here in Minneapolis and putting that power directly into the hands of community. I do want to touch on the complicated social service and just resource landscape. I always wish that there was a repository somewhere, a directory somewhere, and it takes a lot of navigation, I think savviness to make those connections and keep abreast of all of what's out there. And the systems are not necessarily set up in a way that are accessible for the folks that I work with either. So I do want to talk about that. And this is really a systems level issue. So a part of the work that I do too is when there are barriers for whether it's a county administered program, a city program, or hey, we're seeing folks still get arrested who are clients in this program, and this is not the intent. Are there ways to shift what's happening, improve communication for law enforcement to potentially divert those individuals back to us and their case manager rather than arresting them? So a part of this is also, and the work that I do involves the high level decision makers within city and county local government, within the community as well, because there are people in community who are movers and shakers and have that ability to shift how things are, how systems are run. It could be a community-based organization, and they don't necessarily know that their program is inaccessible. And so we bring with LEAD those leaders to the table to be able to talk about and share those experiences, those barriers. Okay, we tried to access this county program. All of this paperwork was incredibly, it was a burden, but also incredibly confusing for even our case manager to navigate. Or we called this number and it didn't work, or we emailed this email address and no one responded. So, you know, I'm, like I said, always happy to field questions and talk about what this might look like in your particular context as well, because it may not completely match up, but there could be ways to tap into those high-level decision makers, those systems level individuals who are responsible for creating and adjusting systems, where there's possibly an opportunity to shift how the system operates to better be accessible, to meet the direct needs of participants, of patients, of clients. And oftentimes it's not intentional barriers either. And so just getting that awareness to the right person could be the shift that's needed to improve your ability to connect individuals with services.
Yeah, Ed, this does sound like a legislative issue, right? The last question in the Q&A here about it's just too complicated and it needs to be simplified. And I have an example of this recently, talking about people getting out of jail or prison and getting hooked up with health insurance. And as the panelists have talked about, that's a key point in life, right? That's a key point. To high rate of overdoses, high rate of death during that period. We really need to get people seamlessly into health insurance. And I was told that there's 3 different state agencies working on it. Every county has its own, it's the state provides it, but the county administers it. And then counties deal with hundreds of nonprofits. And by the end of this discussion, I was lost. And so if I was a person just getting out of jail, there's just no way I would be able to get through that. So to Latasha's point, Ed, how do we simplify this? Give us the answer, Ed.
There's a lot of individuals here in law enforcement and probation officers, so I want to yield more to the experts there. But I will tell you from personal experience, the last time that I was incarcerated in jail, I spent, well, I can't remember what it was, 7 days or something. For those who are who are probation officers, they'll get the laugh out of this one. I unfortunately went in on a holiday, so it was a little bit extended in my case. However, I left with no services. I left with no recommendations. I didn't leave with any of those things, right? The 1119 waiver, I believe it's the 1119 waiver right now, is one of those things that's being debated and supported by many. Obviously, we want to get people into care with things like medical insurance, so they can see providers. Here's where the magic happens in the statistics, right? So when we force somebody into treatment or force somebody into jail, what we're doing is we're removing their ability to choose to interact with services, right? So to the very least, when someone leaves when someone leaves jail, we have to give them the ability to interact with services on their choice, right? And so the way to do that is to help get them access. And health insurance is one of those basic human things that individuals really need to do that. That's why syringe service providers work so well, because what happens is when someone goes into an empathetic environment and they're able to see care, that is the change right there. And so what happens in incarcerative examples is that someone's leaving care and they're not supported with any resources. And so they go out and their mind and body will look to a pattern of behavior that has worked for them in the past. And so what that behavior typically is a return to use. And so what the 1119 waiver hopefully will do, and others, including medically assisted treatment, one of the things we're beginning to really push for is the inclusion of medically assisted treatment in jails as well as prisons. And I do want to Will's point, empathize with those individuals who work in jail and prison, because the systems are completely different. And every county has completely different rules. And so when I'm doing legislating, I'll go up to Beltrami County or to Blue Earth County or to Hennepin, and even I'll go like this, right? So we want community specific, but we want those communities to be educated on best practices and evidence-based care. Because if communities want to talk to each other, that is the #1 game. But if communities are going to talk in draconian dogma, then those communities are being left behind.
Yeah, and I see another comment in the Q&A here about once you get that felony, I'm sure it's even harder to get a lot of these services that you're talking about, Ed and Latasha, that it's a barrier, right?
Will, imagine if I was 21 years old or 20 years old, and I was just getting my master's degree and I was ready to start teaching. Imagine if I had gotten pulled over with meth in my car. How many times was I driving, right? You wouldn't, this would not be my story. This would not be my story. And so that's one of the things we're trying to improve.
So we've got about, to add
go ahead,
Ronda. One more comment about like services and health stuff, right? Our health system is very complicated. Even the way our materials are written, and most people don't know this, Minnesota has one of the higher literacy rates in the world. We're at about an 8th grade level right now. But again, the way these materials are written, the way it is to call different things, and again, working with patients and people in the community, there's a lot of barriers to care in the way that things are written and that they're framed. And so again, if you look at the way things are written, for people who have a fear of that punitive things, a lot of these forms even have punitive clauses written in them when you're signing and saying like, well, are you sure you did this? Are you sure you did this? And if you didn't do this, you can be fined this, or you can lose this. We have to do a better job with those materials as well too.
So I want to thank everybody, and if there's any last questions, feel free to put them in the Q&A. We've got about 5 minutes left. I do want to say that the Minnesota Justice Research Center has been working on this issue on drug testing. We interviewed people that were on probation, community supervision. One of the things we found, and I put our one-pager in the chat, hopefully everyone can see it. One of the things we found is that people get drug tested even if they have no history of drug problems at all, right? And so taking time out of their workday, which usually makes their employers quite angry, driving sometimes 50 miles to get drug tested, even, like I said, if they have no history of a drug problem at all. So one of the things we're really discussing this session, we're not lobbyists, but we like to discuss and educate, is when it's appropriate to drug test at all. And the state of Illinois has recently passed a law for people on parole that you're only drug tested if there's probable cause. So they're actually giving people some rights back. And so that's one of the things we're looking at. But I encourage you to take a look at our one-pager. So maybe we'll just finish up, go around to our panelists here for final thoughts, something to leave us with. This has been fantastic for me. I appreciate everybody in the Q&A. And I think I tried to ask some difficult questions. I hope I did, and you guys just batted them right back at me. I was impressed. So Latasha, maybe we'll start with you.
Yeah, thank you. And thanks for everyone who was able to stick with us for the full time. I would just, leave each of you with the fact that, and I mentioned this before, there are models that have shown evidence of impact. You know, we don't have to recreate the wheel. I think it's more about sort of sharing and spreading that awareness. So I want to leave you all with this sort of a takeaway. If you have additional questions of like, how does this actually show up, or how could this show up for me in the work that I do, or in the spaces that I show up in, I'm always happy to have conversations after this panel for folks to reach out with additional questions and then talk about like, what does this look like? I've seen more community health worker positions or just health oriented positions in community corrections or criminal justice spaces. And here locally in the Twin Cities area, that's where I'm based and where I'm most familiar with. And I've seen that in Ramsey County. I'm seeing more of that in Hennepin County. And so there are examples out there. You don't have to start it from scratch. And so I'm always happy to support and share the pieces of information that I know about that and how that could support you in the work that you do. And as you think about how do I infuse more harm reduction practices in my field of work?
Yeah, just quickly, there was a question in the chat. Yeah, I think we are going to try to reduce drug testing as not being as ubiquitous as it is right now, right? I think that's one reform measure. Thank you, Latasha, and thank you for being part of this panel and yeah, that shift to the public health. I really appreciate bringing that perspective. Rhonda?
I want to say thank you for having me here. I encourage people to look at those stories and just kind of sit with those stories. When we have the ability to change things, we can do it. I will let you know, Eddie was very instrumental in helping change the Minnesota Board of Pharmacy's viewpoints on harm reduction. When he came in and gave testimony, he was a force to be reckoned with, and he made people uncomfortable with the fact of they had to check their bias. So that is one thing that I want people to leave with is check your bias. I'm here for questions. Thank you so much for having me, and I look forward to future conversations.
Thanks, Rhonda, and I really appreciate it, especially in the position you're in, holding these bold opinions, bold statements, because can wear us down sometimes. So I appreciate that. Ed?
It's time to throw back the compliment because Dr. Chakolis is the very first Black woman to be appointed to the Minnesota Board of Pharmacy. And if we want to look at change in action, let's take a look at actual change happening at the top, where individuals who identify as female and Black women are being empowered and actually getting seats at the table. So thank her for that support. First of all, I'd like to say that Minnesota saved my life. Minnesota saved my life in more ways than one. And I live in rural Minnesota, and I partied in Minneapolis. And if it wasn't for the people in this state, and that includes law enforcement officials, law enforcement officers who sat with me on trains while I was smoking and, you know, huddled around me while I was crying, processing trauma, whether it was the 40 treatment centers who taught me what it was like to reframe the way that I view myself, or whether it was the doctors and providers who finally decided to take a chance and provide a safe supply. Each individual saved my life. And it takes a comprehensive look in order to talk to each other and realize that we're not apart here and we're on the same team. Thanks so much, everybody, for coming.
Yeah. Thank you. And thank you to the panelists. And thank you for coming, everyone. I really appreciate it. And Minnesota Justice Research Center will be hosting a legislative kickoff on February 8th, where we'll be talking about some of this legislation coming this year on these issues. It'll be at the Sabathany Center in South Minneapolis. It's on our website if you're interested, but that'll be our next event. Thanks, everyone. Thanks for joining.